Intro Dr. Sarah, trainee. Hi Dr. Ahmed, I have an interesting case today and would like your opinion. Dr. Ahmed, consultant. Of course, Sarah, tell me about it. Case presentation. Dr. Sarah, we have a 30-year-old patient with recurrent early pregnancy loss and short menstrual cycles around 24 days. She has been trying to conceive for over a year without success, and her cycles have been consistently shorter than the average 28 days. Her mid-luteal progesterone level was 7 ng/ml, which seems quite low. This was confirmed by repeated tests over several cycles indicating a persistent issue. Dr. Ahmed, sounds like a classic case of luteal phase defect, LPD. This condition can be quite challenging for patients trying to conceive. Let's break it down step by step. Understanding LPD. Dr. Ahmed, LPD occurs when the corpus luteum doesn't produce enough progesterone. This hormone is crucial for maintaining the endometrial lining. This inadequacy leads to poor endometrial receptivity and can cause early miscarriages. Without sufficient progesterone, the endometrium cannot support the implantation and growth of an embryo, Dr. Sarah. So, weak corpus luteum function leads to early pregnancy failure? Dr. Ahmed, exactly, here's why. The corpus luteum is supposed to support the endometrial lining through progesterone. This support is essential for the first few weeks of pregnancy until the placenta takes over. If it's weak, the lining doesn't transform properly for embryo implantation. This can result in the embryo failing to implant or an early miscarriage. Diagnosis. Dr. Sarah, how do we confirm LPD? Dr. Ahmed, good question. First, a mid-luteal progesterone level less than 10 ng/ml usually confirms inadequate luteal function. This is a key diagnostic marker. An ultrasound can also show a thin endometrium or a poorly developed corpus luteum. These imaging studies provide visual confirmation of the defect. Other tests include basal body temperature charting, endometrial biopsies, historically, and comprehensive hormone panels. These tests help in understanding the overall hormonal environment. Treatment and management. Dr. Sarah. So, how do we treat this patient? Dr. Ahmed, first-line therapy typically involves vaginal micronized progesterone dosed at 200-400 milligrams daily. This helps to directly support the endometrial lining. If there are ovulation issues, medications like clomiphene or letrozole can be used. These medications stimulate ovulation and improve luteal function. Also, HCG injections may help sustain the corpus luteum. This can be particularly useful in cases where the corpus luteum is not producing enough progesterone on its own. And don't forget to check for underlying conditions like thyroid dysfunction, hyperprolactinemia, or PCOS. These conditions can exacerbate LPD and need to be managed concurrently. Prognosis and follow-up. Dr. Sarah. Great, I'll start her on vaginal progesterone and track her progesterone levels. Regular monitoring is crucial to ensure the treatment is effective. Dr. Ahmed. Perfect. Monitor her endometrial thickness and luteal function. This will help us adjust the treatment as needed. Adjust the treatment as needed and keep me updated. Regular follow-ups are essential to track progress and make necessary adjustments. Take-home messages. Dr. Sarah, LPD is a treatable cause of recurrent pregnancy loss and infertility. With proper diagnosis and treatment, many patients can achieve successful pregnancies. Dr. Ahmed, diagnosis requires mid-luteal progesterone testing and ultrasound. These are the cornerstone of identifying LPD. Dr. Sarah. Progesterone support combined with ovulation induction leads to higher success rates. This combination therapy addresses both hormonal support and ovulation issues. Dr. Ahmed. Remember, thorough monitoring and a tailored treatment plan are key. Each patient is unique and requires a personalized approach. Outro. Dr. Ahmed. That wraps up our discussion on luteal phase defect. We hope this has been informative and helpful. Thanks for tuning in, and see you next time.